All right, so in this segment, I want to continue talking about the hips, evaluation and assessment, and help make good decisions based on what you find. So oftentimes, as we talked about in previous videos, the issue with a lot of glute training is that once we have a lot of anterior pelvic tilt and we've got externally rotated hips, for example, okay, we don't want to have a situation where the hip flexors are actually short and they're actually restricted and tight, but then we start training a lot of hip extensor and external rotator muscles from a position of hip flexion. So testing them properly is one of the keys. So what I'm going to ask Frank to do is scoot forward so that his butt bones are pretty much near the edge of the table. You can go ahead and keep going a little bit more. Perfect. Now I'm going to ask him to bring his left knee to his chest, wrap both hands around, and then lay backward. This is the customary hip flexor test. It's called the Thomas test. And what we're essentially looking for is stabilization of the pelvis and the lower back. We got to put it in a certain position so we can get an idea of what the hips are doing around it. Okay? So as we lay down on the back, we pull the knee to the chest, we're posteriorly rotating the pelvis. Oftentimes the biggest mistake with this is pulling it too much. The back is so rounded that we're getting, false positive tests in the hip. So the key is, just for the demonstration purposes, we pull just enough to see the back start to flatten, and that's the position we want to hold it in. As a therapist, I would just generally support him here so he's not doing too much work, and I can monitor if he's starting to pull too much and messing with the results of the test. Now ideally what we're going to see here is we need to see this femur bone drop about 5 to 10 degrees below the level of the table. Okay? Now right now he's on the table, he's still got some of the bone here, so he's clearly meeting the level of the table while keeping the back flat. Okay, but we want to see if he can drop another 5 to 10 degrees. So I'm going to pull him forward over the edge of the table here, and I'm going to see if that leg can drop. Okay, you can see this on the camera here, that he's clearly able to drop about another 5 degrees or so below parallel. So he's good here in terms of attaining hip extension from your viewpoint. Okay, so he can get into the hip extension, but when we change angles, and you see from my perspective what's happening here is his leg is rotating outward. He's got a decent amount of lateral rotation in the leg to accomplish that -5 degrees. Okay, now that may or may not seem important to you, but it is. Okay, now the more restricted we are in the hip flexors, okay, as we start to go down toward hip extension, the only way to accomplish hip extension for a lot of people is to externally rotate their leg as they go down. Okay? Now, the degree to which you have to externally rotate your leg to accomplish hip extension oftentimes is thought to be the shortness primarily of the tensor fasciae latae / IT band. Okay? So the shorter that muscle is, the more that leg is going to abduct, that's abduct and externally rotate. Or we'll see the tibia start to externally rotate as well. Okay? We oftentimes don't see this as the hip is in flexion. So if the leg is hanging here and we've just got generally short and tight one joint hip flexors, okay, so let's see in this position here, we've got the psoas tightness, okay, and some TFL, you'll see this sort of thing. Okay? So this is obviously tight hip flexors, and this has to be cleared before we move to the next step. But for a lot of people, we'll see that the leg will drop significantly. So the person doing the assessment goes, oh, hip flexors are normal length. Well, again, from this view, it looks fine. But from my view, he's got a lot of external rotation in there just to get himself to minus a few degrees from the horizontal plane. This is relevant, okay? So what we want to do is to make sure that we address that as to how the hip is moving in the socket to accomplish that hip extension. Okay? As we do the other side, and again, there are a few techniques that I'm not really talking about here, like repositioning on the table for getting an accurate assessment, and I let that drop. We have a lot of abduction and external rotation on his left side relative to the right. Okay? So again, he's accomplishing that degree of drop from horizontal, but he's only able to do it with a lot of abduction and external rotation. So if I start to bring him back up and I reposition him in a more neutral position, and again, this is relative to the person and how their hip is designed, okay, so I'm going to be aware of that, and I start to drop him down, that's only as far as he can get before he starts to rotate. Okay, if I give him a little leeway and I abduct him, he can get a little further, okay, but again, for every degree of extension, he's got to get a lot more external rotation. Okay, so I'm going to bring him up for a second, and then I'm going to explain this. One of the things and the reasons why this is important is a combination of tests can often reveal problems that are not purely muscular related. One of those things that we're oftentimes looking for with hip extension problems is laxity in the anterior component of the hips. So for example, if we see an IT band that's positive via what we call the Ober test, and the person can't adduct and internally rotate the leg correctly, but yet we put them in the Thomas test position and they have more than adequate hip extension with a lot of rotation, and that leg is kicking way out to the side, this could be shortness in the TFL and the IT band. It could also mean that they have laxity in the anterior ligaments of the hip capsule, okay? Which can also be associated with things like people who have labral tears and so forth, and they have hip pain, okay, because they're compromised in the anterior aspect of the hip. So if we do a lot of glute work and a lot of hip extension work, we can potentially aggravate these conditions significantly without understanding the mechanics and what this person can or can't do, okay? So we don't want to just, prescribe high volumes of exercise in certain things, especially with hip extensions, when we don't understand what's going on with the hip. It is important to do some of these assessments. When all else fails, you can always train everything through the mid-range of motion, but you do have to be careful when you're trying to push excess range of motion in some of these areas without understanding what's happening here. So I hope that helps.